there was an association between HIV status and positive prostate biopsy in a study of U.S. veterans. And you can see over a 5.5-year period, patients that were referred just because either they had an elevated prostate-specific antigen test or an abnormal digital rectal exam, so there was some abnormality that they could feel on the prostate. They had markedly higher rates of prostate cancer in those with HIV compared to HIV negative or where the status was unknown. And in another study, in men receiving antiretroviral therapy, their age, prostate-specific antigen levels, clinical presentation, management, and outcome from treated prostate cancer didn't appear to be significantly altered, meaning that if you found somebody with prostate cancer, you could give them the same radiation therapy or chemotherapy or whatever, and their survival outcomes were exactly the same. So we should be treating prostate cancer as we normally would. Now, Dr. Fried spent quite a bit of time talking about, in the geriatric population, health exams. It was actually in the Canada healthcare system that developed this geriatric periodic health exam. And this was an assessment they developed that's aimed at preventing, detecting, and controlling specific conditions or risk factors. And the GPHE specifically addresses those over the age of 65 and allows detection of the common health issues that require further assessment and or early intervention. And so this is targets like frailty, sensory loss, cognitive impairment, depression, polypharmacy, among others. They screen for quote-unquote risky behaviors, so smoking, obesity, nutrition, medications. It's self-administered. Initial screen takes less than 30 minutes. And they implemented this like 20 years ago, so they were way ahead of the mark. This is a little bit of what national healthcare systems, I think, can do. But essentially, what was the benefits that they found? So they found that chronic diseases, if left untreated and undiagnosed, like diabetes and depression, are causally related to other diseases. So 90% of diabetes and 80% of coronary heart disease can be avoided with behavioral changes, good nutrition, regular exercise, smoking cessation, stress management. They saw a 20% reduction in cancer rates with daily diets high in vegetables and fruit. Mammography screening for 70% of women aged 50 to 69 would prevent a third of the breast cancers over a 10-year period. And fecal occult blood testing in those aged 50 to 75 could reduce colorectal cancer mortality by 15 to 33%. So just having a self-administered assessment. I know some doctors do that. You go in the office and you have the clipboard and you check everything off. But this is a standardized assessment. They were actually found a lot of benefits. So maybe we should be thinking about the same thing for HIV. And maybe instead of 65, maybe we do need to decrease it. Maybe we even need to put it down to 40. I don't know what that age is, and I think that's where the HIV cohort studies will come really be helpful in us trying to figure out at what age should we start implementing these different type screens. There are certain web tools already available for fracture risk and cardiac risk. And this is just to remind me about, when you go into the website and you look at that Framingham equation to find out what your cardiac risk, in one of the large studies that was done, the DAD study, what they actually did was they took calculated rates and looked at them, and they did the Framingham equation, and then they said, well, what is our actually observed rate? And what you see is that over time, with the duration of antiretroviral exposure, that the risk of MIs actually increased over time. And if their observed rates actually were very parallel, right, only 1 to 2% higher than what the Framingham risk was. So maybe that Framingham risk, you could modify it somewhat and you could actually do risk assessments. So this is how we do a Framingham risk now, and I do these in my exam office. What you do is, in the exam room, you pull up the website and you plug in somebody's sex, how old they are, what their total cholesterol is, HDL, blood pressure, whether or not they're on treatment for hypertension, and whether or not they're a current smoker. So in this particular individual, you can see with different characteristics in, his risk is 16%. Well, what if HIV was a risk? and you put that in there, just as what I just showed you on the previous slide, maybe then that risk is 18% or 19%. So maybe these tools could help us if we knew how to create them appropriately for those with HIV. And again, these are the guidelines for treatments of lipids. And the way that you use this is that you count the number of CHD risk factors and determine the level of risk. And so if you have 2 or more risk factors, then you perform that risk assessment, and then you have these lipid goals. Well, if you have less than 2 risks, you don't use this, and people can actually have their lipids higher. But again, what if HIV itself is a risk? So that would be counted there, and just one additional risk then would become there too. And so their goal of where you would want their lipids would change. So I think, again, that's kind of what we need to be looking at. Certainly, and this is the Kaiser Permanente data, which I think has been really interesting, because one thing I like is that they have been showing us through the years that HIV practitioners have gotten really good at prescribing lipid-lowering drugs. And you can see that we actually do have an impact in the sense that, looking at this, that the incidence of MIs and strokes, they kind of go up and then they're going down now. And this is partly related to the fact that we are capturing people early, identifying things, changing diets, better drugs, more attention to the lipids, putting them on lipid-lowering therapies. And you've already seen this from Amy, so I won't belabor the point, but just to say that we actually do have a web tool for fractures. And again, maybe what we need to do, you can see the questionnaire, it's age, sex, weight, height, whether or not you've had a previous fracture, smoking, whether you're on prednisone or other steroid-type medications, rheumatoid arthritis, etc., and you plug all those numbers in, and then you get a report whether or not you feel that person's at risk for developing a fracture. Well, again, what if we could figure out what it is in HIV, and you could modify this and then have that in the questionnaire so that we would know who it would be that may benefit from vitamin D and calcium and possibly the bisphosphonates. And as Amy mentioned, although we don't really have true data on efficacy, we do know from one study that was done by Grace McCumsey that using the bisphosphonates did in fact improve bone mineral density. Now, whether or not that equates out into changing outcomes, we don't know yet. And just a plug for vitamin D, I actually was not as much of a believer in vitamin D, and I'm always, feel very comfortable saying I don't know or I was wrong. But we haven't been screening for vitamin D, and in the last set of guidelines, which just came out on September 1st, we didn't recommend routine screening of vitamin D deficiency. But there's many reasons why somebody could have osteoporosis, and certainly vitamin D deficiency is one. So as part of a quality assurance project, we just started 2 weeks ago screening our patients for vitamin D, and I got to tell you, I was shocked. I mean, the number of individuals that have complete deficiency, and some of it is again, as Amy alluded to, that not intake of vitamin D is maybe less because of lactose intolerance. We're in New York here, we're shielded from the sun, we have a tendency not to be going out, and it's actually much worse in lower socioeconomic groups, again, probably related to not going out in the sun. So just a note that this is something that we can do. We could screen for vitamin D and potentially make a big difference. So I think as we start learning more and more about risk factors for various diseases associated with HIV, or whether it's their therapies or whatever, we need to start building these risk assessments and then incorporating them into our guidelines. So just in conclusion, antiretrovirals are a wonderful thing. I think the New York Magazine, some people came across saying antiretroviral therapy is associated with all these problems. But with antiretroviral therapy, sure, there are side effects, but people are living longer. And so we need to be aware of those side effects. The comorbidities may be occurring at a younger age, and it may be because of this immune activation inflammation. I don't know why. But I think we really need to think about these payoff times, and we need to be really cautious about taking what are payoff times in the general population and applying them to our population. And I'll stop there.